Good morning, ma'am.
So you can hear me, can you?
Yes, ma'am.
It seems 50% of the attendance is, I can see. So I guess we'll have to start. We've already waited for 5 minutes. So we'll start the class. Should we?
Yes, ma'am.
Okay. So today's class is not only congenital lesions of the larynx, but also stridor. And you would get cases, written questions in your theory paper regarding stridor. So what is a stridor? Stridor is an abnormal high-pitched sound produced by turbulent airflow through a partially obstructed airway at the level of supraglottis, glottis, subglottis, and or trachea and bronchi. So you can get this obstruction in any different parts of the airway, as you can see, or in other terms, what is stridor? It's a noisy breathing. If you see a patient with stridor, you would recognize them immediately, because as you don't hear people breathing, making noise, but when a patient nearby, breathes with a noise, then you really have to go close and observe him to see if he has stridor or not. And there's another term which is known as stutter. So you should not get confused with stridor and stutter. They are totally different things. So sometimes you may even get mistaken for, stutter as stridor. So we need to differentiate it. So what is a stutter? Stutter is a low pitched. That was stridor was high pitched, whereas
Excuse me,
stutter
ma'am.
is, yes,
Ma'am, हजुरको स्लाइडै याद छैन.
I know.
हजुर.
उठाउने आएन
अह,
प्रोजेक्टै भएन स्लाइडै.
हजुर.
Again, I have to call Mr. Mahesh then. So inspiratory stridor means when a person is breathing in, so the sound is produced. Expiratory means when someone is breathing out, and biphasic means when they're doing both. So inspiratory stridor suggests there's a laryngeal obstruction at or above the level of the glottis. Expiratory stridor implies bronchial obstruction down below, and biphasic suggests whether the obstruction is at the subglottis or glottic region. तपाईँहरूको बुकमा पनि छ, it's given. Now, if you look at the cause of stridors, you can see acute stridors are produced by laryngotracheobronchitis. पढिसक्नुभयो होला यो. Aspiration of the foreign bodies, tracheitis, retropharyngeal abscess, peritonsillar abscess, spasmodic croup, epiglottitis, very, very common with inspiratory stridor, and sometimes allergic reaction causing obstructions. And in case of other chronic stridor includes laryngomalacia, vocal cord dysfunction, subglottic stenosis, laryngeal web, cyst, hemangiomas, tracheomalacia, and laryngeal papilloma. There's a table in your book, so if you go through that, and you would see these causes. So, and we do get children with stridor, so there are various causes for it, and it's been divided into congenital and acquired. Under the congenital, we see baby born with, very, very common is laryngomalacia, underdeveloped larynx, laryngeal web, subglottic stenosis, sometimes hemangioma may be present, or vocal cord paralysis. Among the acquired, it has been further divided into febrile and afebrile. So under the afebrile, there is papillomatosis, injury, foreign body, laryngeal edema, and sometimes even hypertrophy of adenoid and tonsil could be the cause. And under the heading of febrile, then the acute epiglottitis, acute laryngitis, laryngotracheobronchitis, diphtheria, retropharyngeal abscess, and sometimes infectious mononucleosis could be the cause. So you'll have to know. So what question they would ask is define stridor, what are the types of stridors, and what are the causes. So this question can be asked even during your viva too. This is a picture from your book. If you remember this picture also, then it will be easier for you to remember. Now, if you get a case of a patient with a stridor, how will you go about? How will you manage the case? That, as you know, the management includes history, physical examination, investigation, and treatment. So regarding history, a thorough history would be helpful, or it gives you the clue to understand the underlying cause of stridor. So what do you particularly give emphasis while taking the history? So you have to emphasize on the age of the patient, onset of the stridor, age of onset, duration, severity, progression of the stridor. What are the precipitating events, like does the stridor is produced during crying or feeding, or does it come with change in position, and quality and nature of crying. And you also have to take history regarding aphonia or sometimes associated other symptoms like cough, aspiration during feeding, drooling, or even sleep disorder because of the difficulty in breathing. So you need to even ask whether the child or the patient changes, means whether there is hypoxia or there is a cyanosis during this respiratory obstruction. And you have to even determine if the patient turns blue after some times with the stridor, then that means his or her oxygen saturation is low, and it is gives you alarming sign for emergency treatment. And whether the patient has had endotracheal intubation and the duration of intubation or any other anomalies present, what was the developmental history, feeding and growth history, especially in children, okay, you have to take. And obviously, like any other histories, you also ask about past history, family history, drug history. And after you take the detailed history, what does it say? Do not try to examine the throat in patient with stridor, as this may induce laryngospasm, and there can be a total obstruction of the airway, and which is very, very keta. If there's a total obstruction of the airway, what can happen? There can be fatality, patient may die. So you don't try to look inside the throat when someone is having stridor. So first you would examine the general appearance and you see the signs of respiratory distress. के होता? Sinuses छ कि छैन? Are the patient using the accessory muscles for respiration? Nasal flaring? What are the level of consciousness and responsiveness? So this is I mean, you do this in whether you are posted in medicine or any other department, and you have to look at the vital signs, whether they are normal or it's deranged, and then we start off with the other examination, routine examinations to rule out the cause. And regarding investigations, first thing, when a patient, someone is having difficulty in breathing, and if it's not bad, then you can go around, and then if someone is really having difficulty in breathing and they're turning blue, then you have to look at the oxygen level. So pulse oximetry has to be used to look at the saturation of oxygen. And if it's a moderate to severe cases, then you may even have to do arterial blood gas analysis, and other laboratory tests can also be sent depending on the clinical situation. First thing is to save the life of the patient. Okay, you have to maintain the airway. So you do not wait to do that and do other things. So important things should be done immediately. And you may even have to do an X-ray of neck, AP and lateral view, and even chest to to rule out the causes. And if present, and if the patient can undergo these barium esophagogram, then in order to rule out the vascular compression or tracheoesophageal fistula or other conditions, then you should do it. So these are the list of investigation that you have to do to find out the cause. And maybe contrast enhanced CT scan can also gives us mediastinal masses or aberrant vessels. And MRI may also be helpful in differentiating the lesion of the upper airway and vascular anomalies. So these are the various investigations. You can do pulmonary function test, polysomnography. So these are the list of investigation that you can do in a patient with a stridor. Now, medical care. The treatment of stridor must be tailored according to the underlying or predisposing condition. So this has to be remembered. And emergency management consists of ensuring the airway is adequate. The person, you have to save the life of the patient, okay? So you need to make the airway adequate. If not, there are other conditions like infected, febrile, then in that condition you have to start off with antibiotics. You may have to inject steroids, SOS, okay, in order to decrease the inflammation. Then the airway would even open. Now, regarding the surgical care, you can, if it's a case of laryngomalacia, what do? You wait. You don't have to do immediately anything. You can, that's laryngomalacia is due to underdeveloped larynx, so you can wait till 2 years of time, and unless and until it's very, very severe, then you may have to do a tracheostomy. Otherwise, you counsel the patient and then you wait for the child to grow by 2 years, and if then there's a problem, then you'll have to undergo surgery. But if it's a life-threatening conditions, then tracheostomy is the surgery that you have to perform, okay, and maintain the airway. Other conditions like retropharyngeal abscess, peritonsillar abscess, they need to be drained on an emergency basis. And if if the stridor patient with moderate to severe stridor should be given nothing but it has to be kept NPO, and you can intubate the patient and then do scopies like laryngoscopy, bronchoscopy, and even tracheotomy. So these are the surgical procedures that can be done, okay, in the case of stridor. Now we come back to congenital lesions of the larynx, and out of which the very, very common is laryngomalacia. You would see frequently in newborn babies. You would come across in your pediatric department when posted. And this is also a very, very frequently asked question in your examination at Kathmandu University. So please know this topic thoroughly. So here what happens? The larynx is of an exaggerated infantile type. There's excessive flaccidity of supraglottic larynx, and when the child breathes, the whole larynx is sucked in, during inspiration. It's a common condition, most common condition among all the anomaly lesions, congenital lesions. There's an inspiratory stridor. There's croaking in character, and the stridor increases on crying, and it does get better when the child is put on a prone position. Cyanosis is rare, and voice is unchanged. So there's no change in the voice. As you can see in the picture, so this is when the child breathes. Can you see how the supraglottic part of the larynx is sucked in, and it completely obstructs the inlet? So you need to take a detailed history examination, do an examination. You may even have to use a flexible nasolaryngoscopy and see whether they have all the signs of laryngomalacia. One is, as we said, during inspiration, the supraglottis, they collapse. And another is, when you do look into the larynx, the epiglottis is curled upon itself into an omega shape. If you just look at the previous slide, and you would see how the epiglottis is curled. So omega shaped epiglottis is one of the important finding in laryngomalacia. Now it's a child, baby, newborn baby, so you'll have to reassure the parents. You have to tell them, though it's present at birth, it usually disappears by 2 years' time, but occasionally due to pneumonia the child may have some fatality. But if even after the 2 years of periods the stridor does not get better, then you might have to do a surgery which is known as epiglottoplasty. So you reconstruct that and you maintain the airway. Tracheostomy is very, very rarely performed in a baby with laryngomalacia, unless it's a very, very severe case, then only you would perform. So laryngomalacia, तपाईहरुको बुकमा यो सर्जरीको नाम दिएको छैन होला. It has खाली reassurance and it would disappear by 2 years भनेर मात्रै दिया होला, but the surgery is epiglottoplasty, right? This is what you should write. Now comes the subglottic stenosis. So this is due to the abnormal thickening of the cricoid cartilage or fibrous tissue, which is seen below the vocal cords, as you can see it in the picture. The child remains asymptomatic, but when the child has upper airway, upper respiratory tract infection, then the symptoms would come and the child would have difficulty in breathing, and then the stridor would be present. So it's an inspiratory stridor again, and is partially relieved by rest and worsened by exaggeration, but unaffected by posture. Exertion गर्दा चाहिँ बढ्छ, rest गर्दा कम हुन्छ. It does not, nothing changes with the posture. So this is the character of this stridor. Voice is normal. Feeding is difficult. Okay, takes time for swallowing, and child with a failure to thrive, that you know. Normal subglottic diameter is 4.5 to 5.5 millimeter, but in case if it's less than 4 millimeter in a full-term child, or if it's less than 3 millimeter neonates in a preterm child, then it is labeled as subglottic stenosis. So this has to be remembered. You might even get in your MCQs. So please study this. Now, how do you treat? Okay, first you need to diagnose. So direct laryngoscopy, bronchoscopy has to be done to assess the subglottic area. And remember, subglottic area is the very narrowest part of the larynx. Tracheostomy done unless it's not indicated, you don't do tracheostomy. So only in severe cases you have to do. And in many cases of congenital stenosis improves as the larynx grows, but some of the cases may require surgery. So if the growth of the subglottic allows decannulation after some years of tracheostomy, so if you have to do surgery, then laser surgery would be the best surgery. So it vaporizes the stenosis, but the child would be and long-term tracheostomy can be avoided. And again, 5 to 10% mortality rate is there with these anomalies. So subglottic stenosis can also be present in a newborn child as a congenital lesions. Another condition is hemangioma, subglottic hemangioma. So when the hemangioma is small, it is asymptomatic. So around 3 to 6 months, the child may not have any symptoms. As it increases in size, then you would come across with the symptoms. And 50% of the children are associated with cutaneous hemangioma. So if you look at the other side, you would also see cutaneous hemangioma. And stridor is present with normal cry. And when the child cries, the obstruction increases due to the venous filling. And direct laryngoscopy under general anesthesia will help us to diagnose. You would see a reddish blue mass below the vocal cord in the subglottic area. Now, treatment. You can even give steroids, dexamethasone 1 milligram per kg per day for a week, and then prednisolone 3 milligram per kg in a divided dose for a year. Okay, and another is, if you have the facility, carbon dioxide laser excision would be best. Otherwise, if the child is having severe stridor and you need to secure the airway, then tracheostomy may be done in these conditions. Now there's a condition known as laryngeal cyst. As you can see, the cyst obstructing nearly almost all of the opening in the glottic area. Looks like the cyst is coming from the supraglottic part, maybe the false cord. There can be different sizes of cyst present. Small cyst present with hoarseness and muffled cry. Larger cyst cause inspiratory stridor. So you can do a fiber optic laryngoscope. Though, as you all know, there are two types, flexible and rigid. So fiber optic flexible laryngoscope can also be done. Rigid can also be direct laryngoscopy can also be done under general anesthesia. So once you diagnose, and if it's causing respiratory difficulty, then you would need to do something to secure the airway. So what can you do? One, to reduce the size, you can put a needle and aspirate and evacuate the cyst, or you can even do an IND and suction out the fluid. Another is de-roofing or uncapping the cyst is another method of securing the airway. And the best would be if you have the laser facility, then carbon dioxide laser for excision is the choice of surgical treatment. And sometimes you would even come across a condition which is known as laryngeal web. So this is due to the incomplete recanalization of the larynx or arrest of development. It consists of fibrous tissue, stroma, covered by epithelium in the anterior half of the glottis. Atresia may be sometimes complete also, with a very minimal opening. And the web is seen between the vocal cord and has a concave posterior margin, as you can see. Clinical feature, it all depends on the size of the web. Okay, the symptoms would depend on size of the web. So the child will have a weak cry or aphonia from birth. There can be hoarseness. Inspiratory stridor is present. It exaggerates on exertion, and you can do a flexible, indirect, or direct laryngoscopy and evaluate the size and the thickness of the web that is present in your larynx. So, how do you treat? No treatment in the milder cases. A small web will not causing no symptoms. You may not have to do anything. Thin webs, which can be cut with a knife or carbon dioxide laser. Tracheostomy is essential when, again, all severe stridors. To secure the airway, emergency procedure is tracheostomy. But we do not perform tracheostomy in each and every child because the complication you get after tracheostomy and the dependency after tracheostomy is very difficult to tackle. So if there's a thick web, then the excision of the web has to be done by laryngofissure and a placement of the silicone keel and subsequent dilatation is needed, okay, in order to maintain the opening. So I guess this is all about today's class. So among all these, laryngomalacia is important, keeps coming, frequently asked question. And stridor, you have to know the definition, types, cause, and how do you manage a case of stridor. So I guess this is all about today's class. Any questions? सुनिराख्या हो तपाईँहरूले सुन्नु भइरहेछ Are you can hear me? Hello? You do get questions. Hi. So any questions? So shall we stop then?